Rohan, please record it. So good evening, everyone. Today is our 8th NEBAOI classroom. So today we are going to discuss on CRS, with or without polyp, inflammatory mechanisms, diagnostic approach, and stepwise medical therapy. Now, may I request Dr. Shubhamay Chakraborty to introduce our expert, Dr. Rupa Vedanthan, ex-professor and head Department of ENT, CMC Vellore. Dr. Shubhamay Chakraborty, please.
Thank you, madam. Good evening to all. First of all, I welcome Madam Rupa Vedantam to be the external expert of today's NEBAOI classroom. Professor Rupa Vedantam, she did her undergraduate and postgraduate from Christian Medical College, Vellore, Tamil Nadu. Current affiliation in Christian Medical College, Vellore, Chittoor campus. Earlier affiliation, Professor and Head of the Department of ENT, Christian Medical College, Vellore. Her career highlights: she is the recipient of Dr. P.V. Cherian Award, Madras University, 1987, Dr. Shugabhanam Prize, Tamil Nadu State, 1987, Adjunct Professor, Flinders University, Adelaide, South Australia, 2003 to 2005, Invited Expert, CSOM International Advisory Board, Visiting Professor, Louisiana State University, USA in 2009, Reviewer of 5 Indian and 27 international journals, external and internal examiners of MS ENT and DNB for 37 years, have trained more than 100 postgraduates in ENT, external examiner and assessor for 3 Malaysian universities, started Rhinology Fellowship at CMC Vellore in 2014, invited speaker, more than 100 national and international meetings. She had a publication, more than 110 publications in peer-reviewed national and international journals. Her research areas of interest: rhinology, skull base, and otology. She has the membership in Association of Otolaryngologists of India, Indian Society of Otology, Cochlear Implant Group of India, International Society of Otitis Media, Fungal Sinusitis Network, Indian Academy of Otolaryngology and Head and Neck Surgery, All India Rhinology Society, Skull Base Society of India, and she is also a member of Tamil Nadu branch of Association of Otolaryngologists of India. Thank you, madam. Once again, I welcome you in this NEBAOI classroom today. Thank you very much.
So now our speaker today is Soni, Dr. Soni. Just a minute. Actually, Dr. Anjani is not there. He is supposed to introduce Dr. Soni. He is just joining. Dr. Soni Thinguzam. She has done MBBS from Tripura Medical College, MSCNT Vinayak Mission University, and she has done her fellowship in allergy, asthma, and immunology from Global Allergy Program AIMS Rishikesh and PGI Chandigarh 2023-24 batch. Currently, she is working as assistant professor, Shija Academy of Health Sciences, Imphal, Manipur. So now, actually, Dr. Hiranya ma'am is also not there. She is traveling. So introduction of our moderators also I'll have to do. Dr. Abedda Buragoy. Abedda, are you there? Hello, Dr. Abedda Buragoy. He is an independent practitioner on ENT and allergology, former Joint Director of Health Services, Government of Assam, 40 years professional experience in healthcare, Hiranandani Award winner in 1994. Field of interest is endoscopic ear surgery, aesthetic surgery, and allergology. He is from Lakhimpur town, Assam. And second moderator is Dr. Anindita Das. She is at present professor and HOD, Department of ENT, Tinsukia Medical College. Experiences and area of interest: over 16 years of experience in medical college, passion about clinical training, surgical excellence, and research in otology, rhinology, rhinoplasty, and thyroid surgery. Committed to fostering academic growth and delivering high quality patient care. Honors and achievements are two-time award of Hiranandini Award, Hiranandini 2 Award at NEBAOI, a post fellowship in ASS Hong Kong and NBI New Delhi, mini rhinoplasty fellowship at Indore under Dr. Brajender Basar, and attend hands-on workshop on rhinoplasty, otology, airway surgery, and coblation surgery. So now may I request Dr. Soni to deliver her lecture. Dr. Soni, please, you can start your presentation. Unmute yourself. Unmute yourself.
Now audible, ma'am?
Yeah, you're audible.
Okay.
You share your screen?
Ma'am, is it shared?
No, I can't see.
Okay, ma'am, just 1 second, ma'am. Ma'am, now?
Yeah. Make it full screen.
Okay, ma'am, is it visible?
Yes.
Okay, ma'am, full screen now, ma'am?
Yeah, you can start.
Okay, okay, ma'am.
The time is 30 minutes.
Yes, ma'am. Okay, good evening, everyone. I'm Dr. Soni from CJ Academy of Health Sciences, Manipur. I extend my regards to Dr. Rupa ma'am, Dr. Abhedya sir, and Dr. Anandita ma'am, and all the esteemed members of NEBOICON. NEBOI. Thank you, Dr. Foje ma'am and Dr. Niteshwar sir for giving me this opportunity. And today I'll be speaking on chronic rhinosinusitis, focusing on its pathophysiology and the medical management. So let's begin. So regarding the clinical definition of CRS in adults, it is inflammation of the nose and paranasal sinuses characterized by presence of two or more symptoms, one of which must be nasal blockage or obstruction or congestion, or nasal discharge, which can be interior or posterior drip. In the presence or absence of facial pain or pressure, in the presence or absence of reduction or loss of smell, and either endoscopic signs or CT changes. In endoscopic signs, we have polyp and or mucopurulent discharge from the middle meatus and or edema or mucosal obstruction primarily in middle meatus. In CT changes, we have mucosal changes within the osteometal complex and or sinuses. The duration should be more or equal to 12 weeks. Now again, CRS in children, the only difference here is that the reduction or loss of smell is replaced by cough. The duration remains same. Sorry. Now, today's presentation is actually based on EPOS 2020. So, a small introduction about EPOS. So, EPOS was first started in the guidelines first came in 2005, then in 2007, 2012, and now in 2020. Then in 2020, the main shift or the main key paradigm shift from EPOS 2020 from the 2012 to 2020 is that EPOS 2020 moves away from the CRS without nasal polyposis or with polyposis dichotomy towards management based on endotype, that is type 2 versus non-type 2, and phenotype, localized versus diffuse. Now the classification. So as I've mentioned, there is shift from the phenotypic classification to now phenotypic and endotype. So there are two classifications, primary CRS and secondary CRS. Now the detailed classification. In primary CRS, we have localized and diffused CRS. In localized CRS, we have it is again divided based on endotype into type 2 and non-type 2. Again, diffuse again into type 2 and non-type 2. Examples are for localized type 2, we have EFRS, and non-type 2, we have isolated sinusitis. For diffuse type 2, we have examples are CRS with nasal polyposis or eosinophilic CRS, AFRS, or central compartment allergic disease. In diffuse non-type 2, we have non-eosinophilic CRS. In secondary, again, by anatomical distribution, we have localized and diffuse. And localized, we have local pathology like odontogenic, or it can be fungal ball, or it can be tumor. In diffuse, we have mechanical like the PCD, the cystic fibrosis. In inflammatory, like vaginous disease or vaginous granulomatosis, immunity, like selective immunodeficiency. Now, why are we emphasizing so much on this phenotypic and endotypic classification? So in phenotypic, the strengths are that it is easy to access at bedside. It drives initial clinical approach. But the limitations are that it does not predict the response to therapy and does not reflect underlying immunology. Whereas in endotype, it can predict the response to steroids and biologics, and it enables precision and personalized therapy. In current practice, endotype is inferred from phenotype plus response to systemic steroids and biomarkers like tissue or blood eosinophil, total IgE. Periostin is still under research. No single reliable markers exist yet. Now, some few terminologies. Difficult to treat rhinosinusitis. So patients who do not reach an acceptable level of control despite appropriate treatment, that is recommended medication and surgery, is what we call difficult to treat rhinosinusitis. So what do you mean by appropriate or adequate treatment? So it is adequate phase, after adequate phase, and intranasal corticosteroid therapy with compliance and correct technique, up to 2 short courses of antibiotics within the last year, up to 2 short courses of systemic corticosteroids within the last year. Again, another term, acute exacerbation of chronic rhinosinusitis. It is a worsening of symptoms intensity with return to the baseline CRS symptom intensity, often after intervention with corticosteroids and or antibiotics. Now, what does EPOS 2020 says that it is multifactorial. It has multifactorial etiology. Viral infection probably is the key driver. Rhinovirus drives eosinophilic inflammation. So bacterial pathogens are often absent. Microbial dysbiosis after surgery may be cause. So again, steroids and antibiotics will likely remain the mainstay short-term treatment. But there is very weak evidence for antibiotics again. So prevention of viral infection may be more effective than treating the secondary bacterial flares. The burden of CRS. CRS carries a significant personal and societal burden. Patients report the quality of life impairment comparable to major diseases like the COPD, diabetes, and congestive heart failure. There is also direct and indirect burden. So direct by the use of the healthcare services very frequently, and indirect financial burden like the loss of work or absenteeism from work. It impacts the sleep quality, work and school productivity, cognitive function, concentration, olfactory and gustatory enjoyment, emotional well-being and anxiety, social interaction and recreation. Now, the prevalence of CRS is 5.5 to 28%. This is based on symptoms. Now, if we confirm it by endoscopy or CT, the prevalence comes down to 3 to 6%. And there is prevalence of CRS of 4% in pediatric population. It is positively associated with asthma, COPD, NERD, hypogammaglobulinemia, GERD, also allergy. Now, for allergy, the strength of association varies by phenotype. AFRS and central compartment atopic disease shows strongest allergy link, whereas prevalence in CRS without polyposis or with polyposis is closer to the general population now. Now, CRS and asthma connection. CRS and asthma are increasingly recognized as manifestation of a unified global airway disease, and around 2/3 proportion of CRS patients have comorbid lower airway inflammation like the asthma, COPD, and bronchiectasis. So the practical implication is that always ask about the lower airway symptoms in every CRS patient and vice versa. and coordinate care with the pulmonologist. Improving one airway improves the other. Now coming to the pathophysiology. So CRS results from dysfunctional complex interactions between host factors, environmental triggers, barrier dysfunction. So host factors and environmental factors, there is interaction, and this causes remodeling, like basement membrane thickening, goblet cell hyperplasia, tissue eosinophilia, polyp formation, fibrosis, etc. Now we'll be discussing the host factors and environmental factors one by one now. The first factors will start with genetics and epigenetics. No single gene explains CRS. Instead, dozens of genes mainly mainly affecting the immune system, epithelial barrier, and related pathways are involved. Each contributes small effects. Now there are evidences that CRS is heritable. So study shows that there was a study that was conducted, and in 1,638 CRS with nasal polyposis patients and 24,200 CRS without polyposis patients. So it shows that for CRS with polyposis, the first degree relatives had 4.1 times risk. And for CRS without polyposis, the first degree relatives had around 2.4 times risk of CRS with polyposis, without polyposis. Sorry. Genes are grouped into three categories: immune system genes, epithelial barrier or structural genes, and those which are not easily categorized. So the most implicated genes are immune related. To name some, we can name some as IL-1A, IL-1B, ALOX5AP. So these are some of the genes. Now, epigenetics. Epigenetics is heritable changes in gene expressions without altering DNA sequence. Factors like cigarette smoking and Staphylococcal aureus are both implicated in epigenetic modification in CRS. Epigenetic changes are more pronounced in nasal epithelium than in circulating blood, highlighting the importance of environmental contact. Now, the clinical use of genetics and genotyping is limited to specialized situations like detecting immunodeficiencies, evaluating cystic fibrosis, predicting Staphylococcal aureus carriers, etc. So the limitation of genetics is that there is no single gene that predicts CRS onset, and genotyping is not routinely done in CRS workup. Now, the host factors, we'll be discussing about innate immunity. The first thing that comes is epithelial barrier, the front line of innate defense. So the sinonasal epithelium, it acts as a barrier and an active immune organ. Now, in CRS with nasal polyposis, there is loosening of the tight junctions, cilia malformation, and epithelial mesenchymal transition. Now, I'll give a few examples. Like, for example, Claudin 1 and Zona Claudins 1, the ZO1, these are transmembrane glycoproteins. So decrease in these transmembrane glycoproteins will cause the barrier damage. Another is the E-cadherin. So E-cadherin, they help, and these are again transmembrane glycoprotein. They help in cell-to-cell adhesions. Now, decrease in this again causes epithelial damage. Similarly, the MMPs, the matrix metalloproteinase, these are enzymes that causes breakdown of collagen. So again, increase in this causes epithelial damage. So there is a term called feed-forward loop. So this means that if there is barrier loss, there will be more antigen exposure. And if there is more antigen exposure, there will be more inflammation and more barrier damage, and this cycle continues. So we need to break the cycle early. Next is mucociliary clearance. So ciliary dysfunction is there in CRS. So structural and functional abnormalities are found in CRS with nasal polyposis. Mucous gel strand velocity significantly decreases in CRS. Now the pattern recognition receptors. The innate immune cells, they sense microbes via the pattern recognition receptors and drive cytokines cascades that orchestrate the endotype. So defects in TLR9 mediated microbial defense in CRS with nasal polyposis turbinates may explain the viral induced polyp growth. And in CRS with nasal polyposis, it shows elevated levels of TLR2, TLR5, 4 expressions. Now, the innate lymphoid cells, there are three subsets, 1, 2, and 3. The two is the best studied in CRS, and it is a key driver of the type 2 inflammation. Now the cellular players. So we have neutrophils, monocytes, macrophages. We have neutrophils, monocytes, macrophages, yes, basophils, mast cells, the natural killer cells, and eosinophil. So we'll talk a bit about neutrophils. It causes early phagocytosis and killing of extracellular mucosal microbes. Recruitment is driven by microbial stimulation or tissue damage signals and in interleukin 8. CRS without nasal polyposis is more distinctly a neutrophilic process. But in the subpopulation of CRS with nasal polyposis, patients with relatively low eosinophilic infiltration, neutrophils may play a major role there. It may be the pathologic driver. Neutrophilic infiltration this point is very important. The neutrophilic infiltration are seen higher in Asian CRS with nasal polyposis. We'll skip the other cells and comes to the most important one, the eosinophils. Eosinophilic damage to sinonasal mucosa is believed to be the main mechanism of CRS with nasal polyposis and is considered the hallmark. But the current perspective is that eosinophils are not absolutely necessary for CRS, for nasal polyposis or CRS. Systemic or tissue biomarkers for eosinophilic CRS is important for severe recalcitrant disease, and it carries a relatively poor prognosis. Now, here I've mentioned here that Western or Caucasian polyps, 90% of them are eosinophilic, but the relationship between CRS with nasal polyposis and mucosal eosinophilia is not maintained in Asian polyps. So this is something to be noted. Now, regarding the adaptive immunity, so we have T cells, B cells, and local IgE. Adaptive responses shape CRS chronicity, antigen presentation, and dendritic cells, they shape the T cell differentiation. We have four subsets of T cells: the Th1, Th2, Th7, T regulatory, the Treg. And in CRS with nasal polyposis, Th2 and eosinophils are elevated, but this is mostly seen in Western CRS with nasal polyposis. And mixed Th1 and Th17 with neutrophilia is seen in the Asian polyps usually. Regarding the B cells and local IgE in CRS with nasal polyposis, there is local IgE, a rise of local IgE, IgG, IgA, and IgM. Class switching in germinal centers like follicles in the polyp, they drive the local IgE. Now, local IgE is independent of systemic atopy and it predicts poor prognosis and correlates with staphylococcal superantigens. Now, coming to the CRS inflammatory mechanism. So there are three immune responses. In CRS, one or more become chronically dysregulated in sinonasal tissues. So we have type 1, type 2, and type 3. Type 1, the target is intracellular pathogens like the viruses. The signature cytokine is INF gamma. The drivers are innate lymphoid cell 1 and Th1 cells. Effector cells are NK cells and CD8 T cells. Neutrophils, they cause the main barrier damage. We'll skip type 2 now. I'll come to type 2. Again, in type 3, the target cells are extracellular bacteria, fungi. The cytokines are IL-17, IL-22, IL-23, and drivers are IL-3 and Th17 cells. They have strong neutrophilic infiltration and link to corticosteroid resistance. Now, coming to type 2, I will be discussing more in detail, because this type 2 CRS is the most dominant endotype. So type 2 inflammation accounts for the vast majority of the Western or Caucasian CRS with nasal polyposis, and roughly around 50% of the surgical CRS without polyposis. It drives more drives more severe tissue remodeling. It is tightly linked to asthma and is the principal target for current biologic therapy. Now, this picture, it depicts the type 2 immune response in CRS. We can see the damaged epithelial barrier here. So the epithelial barrier is damaged. Then the ILC2 and the dendritic cells set the process in motion. It is Th2 driven. The main cytokines involved are IL-4, 5, and 13. So if you can see, this is IL-4, 4, and this is 13, and this is 5, and it is this is ILC2 and dendritic cells here. So it's driven by these, and the cytokines involved are these three. Now let's come to IL-5. So IL-5 recruit eosinophils and causes degranulation. 13 causes mucus hypersecretion, barrier breakdown, basophil recruitment, factor 13A production, inhibition of the tissue plasminogen activator, and causes deposition of the fibrin mesh that forms the tissue matrix of the polyp. Now, coming to the IL-4, it is the primary signaling molecule that drives the Th2 differentiation and IgE production. So it induces class switching, forcing the B cells to produce IgE instead of the standard antibodies. So the result is elevated IgE levels, leading to mast cell activation, which contributes to the chronic swelling and mucus production. So again, one more thing is that IL-4 acts as a feedback loop. So what we mean by that is when a naive T cell encounter IL-4, they differentiate into Th2 cells. So this Th2 cell again produces more IL-4, IL-5, and IL-13. So this creates a self-sustaining cycle of inflammation that makes the condition chronic. And the tissue remodeling degree is greatest in type 2 CRS, particularly in terms of fibrin mesh formation and barrier damage. So this type 2 endotype is the hardest to treat and the best target for modern biologics. So by that I mean, so targeting IL-4 here and IL-5. So dupilumab X here and mepolizumab X here, and or omalizumab it X in here IgE. Now this we have discussed type 1 and type 3, the neutrophilic patterns. So not all CRS is type 2. The main thing to be noted here is neutrophils are more prominent in Asian polyps. So whenever we see a CRS with a nasal polyposis, so we should not jump into the type 2 endotype. So neutrophils are more prominent in the Asian polyps. But another thing is that Asian polyps, Asian CRS is westernizing towards type 2, which suggests that environmental epigenetic impact is there, and there is westernization of that, means it's more tilting towards the type 2 endotype now. Endotyping and clinical implications. CRS is not a single disease. Cluster analysis have identified distinct endotypes. So reshaping how clinicians choose between corticosteroid surgery and targeted biologics. So now the environmental factors, we have viruses, bacteria, fungi, and few more. So in viruses, the main implicated ones are the RNA virus, rhinovirus, RSV, and influenza. Bacteria, so the common cells, they are benign and more or even beneficial to the nasal. I mean, it's more rather than beneficial. But in CRS, the microbiome shows decreased diversity and anaerobic enrichment compared to the controls. Again, a few specified organisms are Staph aureus, Streptococcus, Haemophilus, etc. This biosis rather than single pathogen is now the leading hypothesis. Now, regarding the Staphylococcal aureus and superantigens, Staph aureus is not merely a colonizer in eosinophilic CRS with nasal polyps. It actively amplifies type 2 inflammation via superantigens, driven polyclonal Ig production and local immune dysregulation. Biofilms. A biofilm consists of bacterial colony embedded within the extracellular matrix of polymeric substances, which makes it resistant to the environmental stress, host defense, and antimicrobial treatment. Regarding fungi, commensal fungi are present on all the mucosal surfaces, but the important ones are Alternaria, Aspergillus, Cladosporium, Penicillium, etc. Three distinct phenotypes are there: fungal ball, AFRS, and invasive fungal rhinosinusitis. We'll talk about AFRS in little detail. So we have the Ben-Kund major criteria, which should be met to call it as allergic fungal rhinosinusitis, like nasal polyposis, fungi on staining, eosinophilic mucin, hyper sensitivity to fungi type 1 hypersensitivity, characteristic radiology finding like soft tissue differential densities on CT scan. Surgery is the main treatment along with the medical treatment. Then we have allergens, smokes, pollutants, and vitamin. Here, one thing that I want to focus is vitamin D deficiency is associated with sinonasal immune dysfunction. So why polyposis and reoccur? Remodeling, in that we have fibrosis, basement membrane thickening, fibrin deposition, osteitis, angiogenesis, and neural dysfunction. And this explains why CRS is chronic, recurrent, and often treatment resistant. And type 2 shows more severe changes. Now, a few things about the pediatric CRS. If a child comes with CRS, first thing is we have to check for adenoids, because adenoids are reservoir for pathogens. The other differential diagnosis are non-allergic rhinitis, recurrent viral URTIs, a foreign body, and also we should always rule out secondary CRS. Diagnosis and diagnostic tool, I was informed that this will be taken up in a more detailed fashion in the next session. So I've just mentioned about it. CT and nasal endoscopy is the main things, and MRI is done only in selected cases. Cone beam CT, it is an emerging technique. X-ray is not indicated. In histopathology and biomarkers, so in histopathology, particularly eosinophil quantification, more than equal to 10 eosinophils per high power field is considered as tissue eosinophilia. And this is a biomarker for type 2 disease, along with blood eosinophilia, total IgE more than 100, blood eosinophilia more than 250 cells. Now, coming to the management of chronic rhinosinusitis. So the main shift is considering the phenotype and endotype. So for diffuse bilateral CRS, both type 2 and non-type 2, intranasal corticosteroids and saline irrigation remain the mainstay of treatment. Other additional therapies, they layer on top depending on the endotype and disease severity. So this is a flowchart showing the treatment of management of diffuse CRS, bilateral CRS. So appropriate medical therapy is started. It consists of nasal steroid drops or sprays, then saline rinses, educate the technique, and look for proper compliance. Then consider the oral corticosteroids. After 6 to 12 weeks, we check for the improvement. If not, additional workups like CT scan, skin prick test, laboratory tests like seeing the blood eosinophilia or total IgE is done, and then divided into non-type 2 and type 2. If it is type 2, then we go for appropriate medical therapy and consider oral corticosteroid or FES. If it is non-type 2, we consider AMT, that is appropriate medical therapy, and plus minus long-term antibiotics or FES. Again, after 6 to 12 weeks, we see for improvement. If not, in type 2, we go for additional therapy like biologics, and or revision surgeries. And in non-type 2, we go for long-term antibiotics or revision surgeries, and also we should consider secondary diffuse CRS. Now, these are some of the recommendations that I have shown in the table. So the green ones are the ones to be used. So the yellow ones are optional ones, and red ones are the ones to be avoided. So nasal corticosteroids, saline irrigation, systemic corticosteroids, and oral aspirin in NERD. These are recommended ones. Biologics, we have dupilumab, mepolizumab, and omalizumab. Dupilumab is approved. It is anti-IL-4. Mepolizumab is advised if criteria is met. It is anti-IL-5. Omalizumab is still there is insufficient data. Another one is that, again, short-term antibiotics are to be avoided. Short-term in CRS to be avoided. In acute exacerbation, it is uncertain. Long-term antibiotics like macrolides, uncertain. Antihistamines, these are uncertain again. Montelukast, they should be avoided. Probiotics should be avoided. In pediatrics CRS, adenoidectomy is something that should be considered. FES is an option always. Always we should look for concomitant and secondary CRS if it is difficult to treat CRS, like immunodeficiency in CRS. If it is, recalcitrance to the standard therapy and there is rapid symptom recurrence after stopping the antibiotics, always we should think of immunodeficiency in CRS. Also, we have to rule out the secondary CRS like cystic fibrosis, primary ciliary dyskinesia, ANCA-associated vasculitis, and sarcoidosis. And autoimmune and granulomatous disease, they require close collaboration with rheumatology, nephrology, pulmonology, and immunology. So rhinologist manages the local disease, but it should not be, but it's not the treatment lead. Thank you.
Thank you, Dr. Soni. Can you, am I audible to everyone?
Yes,
Hello.
sir. Yes, sir.
Okay, thank you, Dr. Soni, for your very elaborate discussion and in details, to the subject. There are a few questions from the participants, especially from Dr. Fukan. So I think we'll take up the questions. He asks that what is the difference between genomics, genetics, epigenetics, and what is the importance? Would you take up the question, Sony, or anyone else in the the forum? They can take up the question actually. Uh, Difference between genomics, genetics, epigenetics, and what is the importance? Yes. Can you hear me?
Yes, sir. So epigenetics actually is the heritable change in gene expression. So it is something like which is what to say? It is impacted by the environmental factor, like these cigarette smoking or staphylococcal aureus. So it is influenced by the environmental factors. So genetics is already there, but epigenetics means
Sir.
it is influenced by the environmental factors.
Okay.
So, for example, in Asian polyps, it was mostly seen as neutrophilic, but now there are, because of epigenetics, because of the influence, they are more shifting towards the type 2 endotype.
Okay. Thank
I
you.
can just clarify a little bit about this.
Yeah.
This
Yes.
is Dr. Rupa here.
Yes.
So when we talk about genetics, we're talking about a
That's great.
single
And
gene
some
that we
people
are
are
looking
saying
at.
that the rate is whatever the rate is showing by orchid, it is a bit high because to South Korea it should not be so much. Mm. Yes, yes. Yeah, I know it.
Hello.
Yes, I just
Please,
wanted to
please.
clarify
Yes.
regarding when you say genomics, it is the person's whole gene, everything, all the genes is what you're studying within the genome of that person. When you say genetics, you're looking at specific genes for a problem, like the doctor mentioned, um genetics of for sinusitis, for specific aspects of sinusitis. Then that is genetics. And when you talk about epigenetics, you're talking about environmental factors that can alter the gene expression. So really, those are the differences between those three entities. Genome is the whole genome sequencing for that particular individual. Genetics is specific genes that you're looking for a particular disease. And then epigenetics is the effect of any environmental factor that can influence, upregulate, or change the gene expression.
Okay.
I hope that answers the question.
Okay, thank
Yes, ma'am.
you.
Thank you, ma'am. Thank you.
Okay, thank you. And there is another question from Dr. Dipukon. That the filiarine also come in barrier differentiation. Does filiarine also come in barrier differentiation?
Hi, this is Dr. Anandita here. Can I take this up?
Yes, yes.
Yeah. Sir was asking about filaggrin. So this is actually a barrier protein, and this is said to be disrupted in chronic rhinosinusitis. So this is something that has been a latest research that has been going on. So yeah, and it is said that downregulation of filaggrin, it increases the permeability of the mucosa and allows the allergens and the microbes to penetrate the epithelium.
Okay. Thank you very much. Then another question again from Dr. Dipukon. CRS as NP, what it signifies? CRS NP. And at the same time, another question by him is what other biologics antieosinophilic IL-5?
Sir, CRS-NP is chronic rhinosinusitis sense nasal polyposis, and I think that has been beautifully explained by Dr. Soni here.
Oh,
Can I request something?
yes, yes. Welcome.
Actually, before question answer session, the expert will give some inputs of this topic of this disease.
Oh,
Let
Yes,
Madam
okay,
to
sir.
give some inputs
yes,
to
sir.
the audience.
That's nice.
Please.
That's very nice.
After that,
Yes,
10 minutes,
please.
Madam will give her input, and after that, the question answer session will be there.
Okay,
Thank
very
you.
nice. Yes, yes, please, madam, go ahead, please.
So I'd like to request Dr. Rupa to kindly give her expert comment on the
Comment.
entire
Yes,
topic.
Madam, please.
Please, ma'am.
Please.
Well, first of all, I'd like to thank you for inviting me to come in as an expert. I don't know if I'm an expert on this, but all the same, I will share a little of what I know. But I really liked the presentation, Dr. Soni. It was really well done. It is sourced from the EPOS 2020 guidelines, which we tend to follow. My only word of caution is it's important for us to do studies in India and confirm that we are also seeing this. I think we're a long way away from that, but yet we should try to do that and not just blindly accept all the guidelines that they propose. For instance, I do have a little quarrel with a few of the guidelines that are there, but this is perhaps not the forum to talk about it. One aspect which I noticed you didn't mention, but it's not part of EPOS 2020, but it's something based on research we have done here at Vellore. It's on the presence of nasal associated lymphoid tissue. I thought it might interest you, so I'm mentioning it here. And I wonder whether you have any input at all to give on that. And I feel that is something that may be of importance in patients who have sinonasal polyposis. So that is not mentioned in the EPOS guidelines. So EPOS, none of them, either 2012 or 2020. And our findings, we have recently come out with it. We found high levels of intraepithelial lymphocytes. Now, that is not often described. and the frequency or the distribution of these lymphocytes, IELs as they're called, are much more in patients with polyposis than in normal mucosa. So that may lead somewhere, but for the time being, that is something to think about too. The second thing is regarding eosinophils. You mentioned that that is a really good thing that the EPOS 2020 guidelines have come out with, that when pathologists report on nasal polyposis, they should highlight the number of eosinophils per high power field, because it will really help to guide the physician regarding the treatment, as you've shown in your presentation. Unfortunately, that's not done at all in terms, at least there's no numerical value given. Perhaps we need to enlighten them on, pathologists of a particular place or in general about the need for this. And that comes with the clinician actually going to the pathologist and asking them to do that. Because as you've shown, you can tailor make your treatment depending on the percentage of eosinophils you see per, or the number of eosinophils per high power field that one sees. The third point I'd like to make out is regarding the use of biologicals. Now, I know there are many different, you can say, characters within, or people who, physicians, different kinds, that is ENT surgeons, pulmonologists, allergologists, all of whom would like to prescribe biologics. And I'm not sure that we should put it out there to such an extent as EPOS 2020 does, because there's a good role for surgery and close follow-up with different kinds of topical steroid preparations. Not all are mentioned in the EPOS 2020 guidelines. For instance, not just nasal irrigations, but nasal irrigation, not just with saline, but with steroid. Things like that, budesonide irrigations. They make a big difference as compared to simple steroid nasal sprays. So that those things are not highlighted. In practice, this is what we find, that they are quite effective, and not every other patient requires. A very small percentage of patients really may require biologics. Then finally, just one point regarding biofilms. That is something that hasn't been studied to a great extent, nor is it mentioned too much in the EPOS 2020 guidelines. I think there is a role for, looking for biofilms as a cause for recalcitrant sinusitis which persists. Again, thank you. That was a nice presentation.
Thank you, ma'am, for the inputs.
Nindita and Dr. Abhyutada, can you please take the questions now and give your valuable inputs also?
Dr. Soni, I must congratulate you on such a wonderful presentation. It was quite detailed and based on EPOS 2020. And some of the questions have already been taken up. Now, Dr. Fukan has asked about what other biologics in IL-5, what other biologics IL-5 or anti-eosinophilic are there? I guess that is what he's asking. You have already mentioned about omalizumab and mepilozumab, but he's asking if there are any other biologics. So this question can be taken up by anybody.
Well, I can just mention that resluzimab is there. It's also an anti-IL-5 biological monoclonal antibody. So that is something that is available and has been used in some studies.
Thank you, ma'am. And the next question is, how many eosinophils in high power field along with total IgE in AEC count? So
it's, I've shown earlier that it is more than 10. for high power field, and for blood it is more than 250, and total IgA more than 100.
Okay. And then he's also, Dr. Fukan is also asking about TSLP and anti-TSLP. So if anybody can take up this question. TSLP in chronic rhinosinusitis and the TSLP blockade that is being now studied for CRS. Hello?
Nirupa ma'am, can you?
Hello?
Hello, ma'am.
Yes. Were you trying to ask me about it?
Yeah,
No,
because
sir.
ma'am, if you
Anybody
could
can. If
kindly
you
take
can.
up this question.
Yes.
This is really not in something that I'm an expert on, unfortunately, because I think this is still in the phase or realm of bench research as yet. It is definitely not that is something that is freely available as of now. This is the thymic stromal lymphoid thymic stromal lymphoid protein, I think. So it is not something lymphopoietin, thymic stromal lymphopoietin. That's what it is. And it is a kind of epithelial derived cytokine. And it's really not something that is easily available that one can test for. But I'm sure with further studies, it is something that, people will talk about and things that we can test. Even the IL-5, IL-4 is not something that is freely available commercially for one to test. It is still in the realm of bench research right now.
Thank you, ma'am. The next question is directly to you, and this is by Dr. Akriba. She's asking you to share your experience of AERD with nasal polyps and how to diagnose and manage these cases.
Okay. So with AERD, it is resembles all other types of eosinophilic chronic rhinosinusitis with nasal polyps. Okay, so there's a whole bunch of eosinophilic chronic rhinosinusitis, which includes AFRS, eosinophilic mucinous rhinosinusitis, and of course AERD. So when you get a patient clinically, it's not something that you can make a diagnosis right away, except that there are a few clinical or phenotypic features in patients with AARD. They are generally older. They generally don't have atopy to such an extent. And allergic mucin in the way that we see in allergic fungal sinusitis may not be so evident. In contrast, in patients with allergic fungal rhinosinusitis, you will see the classical peanut butter like allergic mucin. Patients may be younger, and atopy is much, much more common. Now, if you were to do laboratory tests, you'll find high levels of absolute eosinophil count and IgE in most patients with allergic fungal rhinosinusitis, but not so in AERD. That is not something that you will find. Then, of course, patients with AERD, they have the Samter's triad, which we know, sinonasal polyposis, aspirin hypersensitivity, and bronchial asthma. So bronchial asthma is it's a part of the disease in AERD. Not so in allergic fungal sinusitis. We don't see it as often. Okay, maybe less than 1/3 may have bronchial asthma. So these are basically the clinical distinguishing features. Some people say that AERD is more common in females. AERD has some relationship to diet. There are certain dietary factors that can exacerbate AERD. For instance, foods that contain salicylates like onions, tomatoes, common things. Or wine, people who drink wine a lot, they all of these things can actually worsen AERD. So it's a good idea to take a history like this from such a patient. In terms of diagnosis, of course, you would need to, as Dr. Soni has said, you histologically you could diagnose. You separate the allergic mucin from polyps. Polyps are very standard edematous mucosa with maybe an eosinophilic infiltrate, which you will see in allergic fungal, but not so much in AERD. The allergic mucin will contain fungal hyphae in allergic fungal, but not in AERD. And right now, I don't think we have these urinary cystinyl adenate at the levels that we can test here in India. I'm not too sure it's available, but that is yet another way in which you can test for AERD. So these are really the differences, okay, between AERD and other common causes of eosinophilic chronic rhinosinusitis.
Thank you, ma'am. Thank you for your
You're
detailed
welcome.
explanation. Our next
Okay.
question is by Nitishore. He's asking about the role of steam inhalation and is it advisable?
Well, steam inhalation is really a kind of non-specific treatment for any kind of upper respiratory inflammation, I would say, whether it's an infection or just an inflammation, viral or bacterial. And there is no harm in doing steam inhalation. Yeah.
Dr. B.N. Sharma lauds Dr. Soni for her excellent presentation as well as the expert comments by Dr. Rupa and Dr. Anandita. And then Dr. Ranjit Kumar Lal, he is asking about the duration of medical management and how to assess when to go for surgery after medical therapy. Anybody can take up the question? Hello.
Well, I can just I give my input into the way we handle it here. Usually, a patient with chronic rhinosinusitis, although Western literature talks about giving nasal steroids for a prolonged period of time, reassessing, and then treating, we find most patients are not very keen on taking this. They've already had multiple courses of steroid therapy and they are not very happy. So if a patient has a nasal score or grade 3 or stage 3 nasal polyposis, we would go ahead and operate on these patients right away. Medical therapy may be more effective for chronic rhinosinusitis without sans nasal polyposis. I think that category of patient definitely one should consider medical therapy. Try everything possible. Check whether they are immunocompromised, do a pus culture and sensitivity and treat with the appropriate antibiotics for at least 6 weeks and then review and then decide on whether surgery is required.
Thank you, ma'am. The next question is there any role of SPT and slit in CRS? Skin prick test and sublingual.
Skin prick test is one thing and sublingual immunotherapy is different. So when we are talking about skin prick test, we're talking about patients with allergic rhinitis with rhinosinusitis. So then that's an entirely different pathology altogether. We're not talking about polyposis at all. We're just talking about allergic rhinitis with rhinosinusitis. Now here, these patients definitely should have a skin prick test prior to commencing therapy. For one, we want to confirm that it is an allergic rhinitis and not a vasomotor rhinopathy or any of the other kinds of rhinitis that can be present. So doing a skin prick test is essential. And it should depends on where you stay also. So the allergens that you test for should be varied and based on what you see commonly in the area that the patient stays in. So yes, that should be done. Now, slit is a completely different thing. That is sublingual immunotherapy. Sublingual immunotherapy is what you give as actually it is the primary treatment of allergic rhinitis. You would say the most specific treatment, but it isn't often what we give as the first line of treatment. The first line of treatment should be based on whether the patient has a mild intermittent allergy or a persistent severe allergy. That separation should be done very carefully with a clinical assessment. Following that, patient undergoes an endoscopy. You see whether there is any polyposis, any structural abnormalities like a deviated septum, concha bullosa. Look for any other, problem that the patient may have. Is it a secondary sort of rhinitis or sinusitis kind of problem? Having done that, the patient should be treated with antihistaminics. We usually start with steroid nasal sprays, topical nasal steroids, and you could give antihistaminics with leukotriene antagonists for a specific period of time and then reassess. I think if patient fails, and I think those are EPOS guidelines too, that if they fail this primary therapy, then you could go on to immunotherapy, of which sublingual immunotherapy or either sublingual or subcutaneous can be given. In India, it is actually so far the drug controller of India has not approved this SLIT as yet, but I know that there are many centers that are giving sublingual immunotherapy.
And the next question is by Dr. Linadri Kolita. She's asking how long antibiotics should be used and what is the antibiotic of choice in CRS? So Rupa ma'am would again like to call upon you to answer
Okay.
this.
Okay. So in terms of antibiotics, according to the EPOS guidelines for CRS sans nasal polyposis, a long course of macrolides is what is advised. In practice, we rarely do that actually. We usually tend to look at if it is an immunocompromised patient, we would do a pus culture and sensitivity and give the appropriate antibiotics for at least 2 weeks and then reassess and decide whether the course needs to be continued. In a non-immunocompromised patient, I would say just from experience, and really we do not have publications on the subject, but just from experience, we would tend to give something like a broad spectrum antibiotic, which would be given for a sufficient duration of time, something like, say, amoxicillin clavulanate or cephalexin or cefuroxime, something like that, which we could give for a sufficient length of time, and not like a macrolide, which really is addressing maybe staph and a few gram-positive organisms, not really meant for gram-negative. I think a broad spectrum antibiotic would be more effective. Yeah, because this is controversial and somebody else may have some other way of handling it, but this is how we handle it.
Thank you, ma'am. And
Sure.
there are no more questions. Fukan sir is asking about macrolide and doxycycline. You have already answered that. And then there are some more chats thanking you and thanking Dr. Soni for her wonderful presentation. Dr. Fukan has said that tezepelumab monoclonal antibody is an anti-TSLP thing, and I think that is still as the
Yes, it works on TSLP.
Then thank you, ma'am. And those were all the questions, and that has been taken up by our expert. Back to you, Dr. Fauzia.
Yeah, and anything, Dr. Abedada, you want to say anything?
No. Yes, it's a very nice discussion today, so elaborate and deep discussion with the, feedback from Dr. Rupa ma'am and the speaker, Dr. Soni, and all the participants. Really, it is very beneficial to all of us. That's all what I can say today. And thanks to all the participants, especially the speaker and our resource person, Dr. Rupa ma'am. And thank you all. That's all from my side.
Thank you, Abedada.
Thank you.
Okay.
Thank you.
Welcome.
This is my part to give the vote of thanks. So, respected President, esteemed faculty, and dear colleagues and participants, good evening. On behalf of the Scientific Committee NEBAOI, it is my privilege to propose the vote of thanks for today's enriching classroom session on chronic rhinosinusitis and its evolving concept. We extend our sincere gratitude to our expert, Dr. Rupa Vedantam, for her valuable insights and guiding perspectives that truly enhance the academic depth of this session. Our heartfelt thanks to our speaker, Dr. Soni Thingujam, for a clear, structured, and clinically relevant presentation covering phenotypes, inflammatory mechanism, and the stepwise approach to the management. We are equally thankful to our moderators, Dr. Abhidya Buragwai and Dr. Anindita Das, for steering the session smoothly and adding meaningful perspective. A special thanks to all the participants for your active involvement and insightful discussion, which made this session truly interactive and worthwhile. Thank you once again. Have a pleasant evening. Thank you very much, everyone.
Thank you, madam. Thank you very much.
Ma'am. Thank you, sir.
Hiranya বাইদেউ এতিয়া জইন কৰিছে। Dr. Hiranya ma'am has joined.